Hello, welcome to the second episode of Dr. Foot TV. I have had quite a gap from the first episode. I've had quite a lot happen in the last week or so with the COVID-19 pandemic. Some of it's been really scary. So I've had friends of the family that have passed away. We've had other close relatives that have been taken into hospital but are fine now. I hope wherever you're listening, your friends, family, loved ones, neighbours are well. I know we have lost in the UK so far today over 10,000 people, which is a travesty. But I wanted to get back to making some videos to help some runners out there. So I'm getting a lot of emails, a hell of a lot of emails from patients all over the world that have taken up running and now have started to get pain. Today's episode is going to be about iliotibial band syndrome. Okay, so we're going through the most common running injuries. The previous video was about patellofemoral joint pain. Iliotibial band syndrome is when you have pain along the outside of your knee. Okay, it can be a particularly sharp pain. Some patients describe it as a burning pain. It can radiate down the thigh into your calf muscle as well, actually. And it's particularly bad when you run downhill or when you're running down the steps. But it is known as an overuse injury rather than a traumatic injury. And it's been associated with two things. With hip abductor weakness, which is weakness on the outside of your hip, the muscles on the outside of your hip, and it's also been attributed as an overuse injury. So you're peaking your loads too quickly. So what is iliotibial? If I can get my words out, what is iliotibial band syndrome? Why do you get it? Well, first of all, the iliotibial band is like a type of fascia. It's a dense, fibrous connective tissue which originates from the tensor fasciae lata, which is further up in your thigh, and your gluteus maximus muscle. It runs down the outside of your thigh and it inserts into a bit on your tibia called the Gerdy's tubercle. It's a great name for a piece of bone, isn't it? It inserts into the Gerdy's tubercle and fans out. There's been various discussions about its actual role, because it is connective tissue. There's been various discussions about what it does, but we do know it can get agitated. Okay. As I said, the primary symptoms are this sharp pain on the outside of your thigh that can radiate. It's not always, so if you've got pain on the outside of your knee, it's not always that. There are other things that it can occur. So some of the things that I'm often thinking about is conditions like a stress fracture, especially for long distance runners, people that have just started running marathons. I'm also thinking about something called biceps femoris tendinopathy. I'm thinking about, we've got the lateral collateral ligament, the meniscus, there's a whole lot of other things. There's a fat pad inside here, there is a retinaculum, there's a lot of different structures that can get damaged, okay? But it very often is iliotibial band syndrome. But when I have a patient in clinic, I would do a much thorough examination of the knee and different kinds of tests that can let me know if they do have that. One of the tests that I do perform in clinic is called Olber's test. I'll try and find a video and put it up on screen for you, and that's a good way of testing if the patient has got iliotibial band syndrome. You test for tightness, and you can add in some extra knee flexion and extension, which is one of the primary reasons why you get it, and that can lead to pain. So how do we treat it? Well, as I tell all my runners, load. We need to manage the amount of load going through your joint. So yeah, we may alter your activities, the type of running you're doing, uphill or downhill. We may look at your trainers, but primarily, I never ever inject this. In fact, I don't do shockwave to this. This is primarily a exercise based treatment plan that I give for this, and I also recommend orthotics. So I'm going to cut away to the park where I'm going to go in about an hour or so, and I'll show you the exercises I do. After that, I will show you some of the orthotics that you can try. Orthotics, as you may hear me on a million occasions, are not a magic bullet. If you don't combine them with exercise treatment, they're just not going to work. So, but let me show you the exercises that I often recommend to patients. Finally, before I forget, sometimes you can get this snapping sensation. It's like an audible snap, and people panic and think, "Oh my god!" It's the iliotibial band flicking over the bony prominence. It's not gonna tear. It's a very dense fibrous connective tissue. It doesn't tear very often. They've done studies with army recruits, because it happens a lot in the army, and they found that just by reducing the type of activity and doing certain exercises can make a big difference, but it doesn't tend to tear. Let me show you the exercises. Hello, welcome to a very windy, cold park where I came for my morning run. I wanted to go over the iliotibial band exercises that I was talking about. Now, the first one I'm going to talk about is the iliotibial band stretch. You can't theoretically stretch the iliotibial band because it is not muscle, it's connective tissue. Well, you could stretch it, but you need a lot of force to stretch it. However, I think the iliotibial band stretch can be effective because it gives you some neuromuscular relief, which is, I think, has got some benefit to it. So what you want to do is put the injured leg behind you like this and reach over and try and stretch towards that injured leg. So let me just come back a bit more. Injured leg behind you, come over, try and reach out and stretch the iliotibial band. I'm going to go through 2-3 other exercises which I think are really important if you've got iliotibial band syndrome. I can't park anymore. It was too windy and too cold, so I thought I would finish off the iliotibial band rehab exercises in my front room. It's better than being cold in the park, isn't it? Let me go through the different stages of rehabilitation. Now, you will hear me talk about this a hell of a lot. When I tell my patients to do rehabilitation, I'm looking at 4 to 5 different stages. Initially, I'm looking at neuromuscular control. Then I'm looking at neuromuscular and endurance, and then endurance and power, and then finally, for some of my elite athletes, power. So for neuromuscular control and for iliotibial band syndrome, I like the sideline raise. So for sideline raise, I like the patient to lie down like this with both knees bent, get the leg that is affected, and I want them to raise it up and bring it back down again. Raise it up, bring it back down again. Couple of things. So make sure your foot is pulled up towards you. Make sure you're not leaning back too much or leaning forward too much, so you've got a neutral spine. I often tell patients, pretend as though you've got a pole going through your hip and it's holding you down and you're going up and down. Now you can go into a plank version of this, which can be very effective. I also like later on, so when you start doing endurance, I start asking patients to use a band and do the same exercise with a band. You should feel this just on the side on your glutes here. That's a very good exercise initially. Also, while you're here, you can also do the clam, which really should be done like this. I tend to recommend at a later stage to lift both feet, have them further apart and do it. But initially, and the initial stages, have them together, and you also should be feeling it there. Now, as There are many other exercises that I can show you, but there's one other exercise I want to show you. This is normally done later on in the rehabilitation, and we're really working on trying to strengthen the gluteus medius, which is on the outside, and it's one of my favorite exercises. It's called the fire hydrant. You can have it below the knees or above the knees. You want to stand like this against the wall, and you are literally moving out that way. You should feel it in the side of your pelvis, in your hip. What you don't want to be doing is moving your whole body, and you don't want to let the knee come all the way back in. So from here, you're really going out and back down slowly. You can also work into extension here to try and work some of the muscles further up in the center of the glutes. So it's this way and that way. Now, the reps, the sets, and everything else really is dependent upon the patient. If you don't know what kind of rep range to do or sets to do, contact me and I will let you know what I think is suitable for you, depending on how long you've had the injury, the kind of activities you're doing, and so on and so forth. As the patient gets stronger, and in certain individuals that are doing sports that are multi-directional, so not just running, talking about my footballers here, and rugby players, I might be working on some agility and some other types of proprioception so that they are stronger in multi-plane movements also. So I hope that was helpful. It's different to being in the park. I'm a bit warmer here, and I shall speak to you soon. I hope you found those exercises beneficial. So the stretch, the iliotibial band stretch, as I said, you can't really stretch the iliotibial band. It's made from a very dense fibrous connective tissue. However, I do think if you do stretching of the iliotibial band, it can be beneficial just from a neuromuscular sense, and that relieves the symptoms. Some people use a foam roller and they roll on their side for the iliotibial band. They find it useful. For me, it's always about strengthening the hips, the hip structures, to try and alleviate the discomfort. So the sideline raise I think is great. I think I would first start off with just getting the form right, and then I would add in the green TheraBand. You can buy these from eBay or Amazon. They're not expensive at all. The clam is also a good exercise. And then further on down the road, after you've got used to those exercises, you may want to have a you may want to try the fire hydrant in two different motions. So in abduction and in moving back, as I showed in the video when I was in the front room, because it was way too cold in the park today. Way too cold. What else? There are some studies that have used a single leg squat and hip hikes. I'm not a great fan of them personally. I don't tend to give them out to my patients. However, I do know some practitioners that do use those exercises. If you have any doubt, reach out to me. I will send you a PDF with the exercises that I tend to give to my patients. Let me also say that if you are unsure, go and visit a physio, go and visit a sports podiatrist. If you're not getting better from the exercises, then go and get assessed properly. As I said previously, there are many other different causes of pain down the outside of your knee. Okay, so exercises aside, and we've spoken about load as well, and not doing too much too quickly, and controlling the amount of uphill and downhill running you're doing. Orthotics can be useful, in my opinion. So these are the Dr. for Sports insoles, and they have a wedge on the outside of the heel. I would recommend, if you're going to go for something like this, a 2-degree wedge would be more than enough. I'll put the link in the bottom of this video. Have a look at them. They're not a magic bullet. You have to combine them with strengthening exercises that I spoke about before. I find them useful for my patients. Okay, I'm not sure if other sports podiatrists and physios may may use orthotics, but I do find orthotics have a place for the treatment of iliotibial band syndrome if they have a wedge on the outside of the heel, because the vast majority of the discomfort you get with iliotibial band syndrome is on initial heel strike, because that's when you get the pain shooting up your thigh and your calf muscle in sometimes. So this can help to alleviate some of the discomfort, but you have to combine it with the exercises. I hope you found this video useful. The next video was meant to be about medial tibial stress syndrome. However, I've had so many requests regarding making a video about ankle sprains, because everybody's getting ankle sprains. I told you, everybody's running at the moment. So everybody's getting ankle sprains, and I want to go through a comprehensive rehabilitation program for ankle sprains. So that will be the next video. Take care of yourself, stay healthy.